Today's topic is global mental health, home and abroad, and we're proud to have Cardinal Health as our partner since 2009. We've done a lot of topics on global health. We've never done mental health. It's sometimes easy to think about the trauma in the world and the tough things going on and how that can impact people's physical health, but think about it from a mental health perspective too. And it's an important question locally. So thank you, Diane Radigan, who's here from Cardinal. We appreciate the support for what you do every year. We'd also like to thank some other supporting sponsors, Nationwide Children's Hospital, Dr. Kelleher, and Squire Patton and Boggs, Pat Cornelius, as well as our promotional sponsors. Franklin University is here. The Adam Board, Adam H., thank you for your support in getting the word out. So please join me in thanking these important groups. All right, to introduce and welcome you today as a board member from the council as well as one of our sponsors, please join me in welcoming Pat Cornelius to the podium. Pat.
Thank you, Pat. Thank you, Patrick. They asked me to make provide some sort of introduction and invitation to everyone, and as the father of 3 daughters, and maybe say something interesting, as the father of 3 daughters, I find myself generally incapable of saying anything interesting or profound anyway. So we wrote it all down. So good afternoon. It's my pleasure on behalf of more than 1,500 Squire Patton Boggs lawyers working in 45 offices in 21 countries to be one of the sponsors of today's program and to welcome you. I'm looking forward to the talk, in part because my work specifically is largely focused on healthcare, transactional, and regulatory matters. So the topics being discussed today are specifically relevant to my healthcare clients in the United States and abroad. However, they also are certainly relevant to employers and societies in general. And this, of course, can lead to policy actions, which now in today's world, as it becomes ever more connected, can have implications across borders. So, as we know, the world is becoming ever more connected, and issues like today's topic, which a few decades ago probably wouldn't impact outside one's own region or locality, now they do. So for this reason, I believe the work that the Council is doing to bring people together to examine global issues such as this one are important. And to come to the point, that's the reason Squire Patton Boggs is sponsoring it and continues to support the Council and its good work. So, the topic of global health in the world and locally is a topic that isn't talked about that often. As Patrick indicated, the Council has done a number of presentations on global health, but not mental health. However, as the email sent around by the Council inviting you said, in 15 years, depression alone will be the #1 cause of disability globally. Despite that, cases of people who suffer from mental illness are often overlooked, and the magnitude of undiagnosed and unaddressed mental health problems continues to be high. It is estimated that 120 million people globally suffer from depression alone. About 1 million people commit suicide every year worldwide, and approximately 20 million unsuccessfully attempt suicide. In the United States, suicide is the 8th leading cause of death. Another life is taken every 17 minutes. Mental illness is still stigmatized in many cultures, forcing people to live in denial, frustration, and loneliness while being prevented from seeking help when they require it. The global epidemic is just as important here at home in Central Ohio. My wife is a social worker who works, she isn't here, but I'm still not going to say for how many years, in emergency rooms and clinics, and she has seen how many of our local immigrants and refugees have faced violence or extreme poverty in their country of origin, leading to increased needs for trauma-informed care, including in the mental health area. As you can see, global mental health is an increasingly important topic, and I'm happy that Squire Patton Boggs is a supporting sponsor of this program along with Nationwide Children's Hospital and the presenting sponsor, Cardinal Health. I would like to now introduce Ms. Diane Radigan, who's the Vice President of Community Relations at Cardinal Health, as well as one of the biggest supporters of the Columbus Council on World Affairs. Welcome.
Thanks, Pat. It's great to be here again. As Patrick mentioned, I think we've done this for about 8 years and really try to bring in notable speakers. We have two terrific folks today who are going to be talking with us and maximize their time together. So we had a nice conversation last night as well as some additional conversation this morning, and then it kind of culminates here with a broader community conversation. It's been a great 8 years working on this, and I think the important part of it is we learn how we are more similar than different. Whether it was the topic around obesity today, mental health, maternal health, child health, birth to 3, we have more in common than we do different, and that's important for us to learn at this point. I want to thank Squire also for supporting this year. Nationwide Children's, you've been every year, right, Kelly? So thank you for that. Dean King, I think he is here from Franklin University. Thank you also, Franklin, for continuing to support this. You know, our world is pretty crazy right now, and so the work you do, Patrick, is probably never more important as folks look to have us be isolationists and only think about ourselves. I think we have to continually push out that we need to see and view others as part of us. So it's my pleasure to introduce Dr. Raviola and Dr. Duffy. And so I'm going to read a little bit here, excuse me for that, but there's so much about them, honestly. This is just the tip of the iceberg of these incredible men. Dr. Raviola is a board-certified adult and child adolescent psychiatrist and an assistant professor in psychiatry and in global health and social medicine at Harvard. He's also the medical director of the Psychiatry Quality Program in the Department of Psychiatry at Boston Children's Hospital. Dr. Raviola studied and has written on child and adolescent mental health concerns and the mental health and well-being of healthcare workers. He's published on topics in clinical psychiatry, global mental health implementation, disaster psychiatry, research in ethnography and cultural anthropology, HIV/AIDS, and mental health policy. That's a lot. He, as an advocate for community and global mental health concerns, he promotes incorporating effective evidence-based mental health programs within existing community and mental health care and healthcare infrastructures. He works to integrate mental health services into the care provided at Partners in Health. I bet everybody here is familiar with Partners in Health. Who knows Partners in Health? Mountains, yeah. Pretty impressive. Supporting local team leaders in Haiti, Rwanda, and elsewhere on issues related to mental health care delivery. He oversees clinical training and research efforts relating to mental health in collaboration with in-country colleagues. Thank you for being with us. Jim Duffy has a wonderful background as well. He began his training in San Antonio, which is a border community, and from there, I think was the beginning perhaps of your interest in issues related to immigration as well. He's a pediatrician and a child psychiatrist. He's practiced for 25 years in the community. He's an entrepreneur. He started a community health clinic in a lower income, more impoverished area of Springfield, and that clinic grew from nothing to an $8 million business over the course of its lifetime. He's been at Nationwide Children's, focusing on foster care. He's involved in many leadership roles at the Academy of Pediatrics. Is chair of the Academy of Pediatrics Foundation, where they focus on literacy for children in foster care. He's advocated at the state level. He teaches at Dayton Children's and has done mission trips abroad to help children. He is currently the policy chair in the Council on Community Pediatrics for the Academy of Pediatrics, and recently co-authored the chapter on immigrant child mental health and poverty in child health. So we are really fortunate to have these men with us today. They live a life of service. They have put many, many different things into their world, and they are not afraid to speak up and be advocates where needed. So thank you for being with us. Please join me in welcoming them.
Thank you. Thanks everyone for being here. I've had a wonderful time being here, and I've met some incredible people here. So I don't have a lot of time. I'm going to tell some stories. I'm going to show you some pictures. And I'm going to try to leave enough time for some discussion. So Partners in Health is an organization. It's a non-governmental organization that works in 10 countries. We have 15,000 staff. Probably only about 200 of those staff are U.S. nationals. Most are local nationals. And many of them are community health workers and people who live in the communities where we work. It's a healthcare delivery organization founded in Haiti in the early 80s. We have programs in Chiapas, Mexico, Peru, Sierra Leone, Liberia, Malawi, Lesotho, Rwanda, and Siberia. The history of Partners in Health really goes back to the HIV epidemic and really building programs to deliver services for people in very poor communities suffering from HIV and also tuberculosis and multi-drug resistant tuberculosis. Fundamentally, what happened with the President's Emergency Plan for AIDS, George W. Bush's signature healthcare program, and other important initiatives in the 90s and 2000s was that through HIV care, HIV was really a Trojan horse for building primary care systems. And as HIV rates have now started to go down, I mean, the HIV rate in some of the countries we work is less than 5%, there really has been more of an opening to build more integrated systems with non-communicable diseases, things like diabetes. There was some stuff that came out yesterday about the burden of diabetes globally, and also mental illness and mental disorders. So Partners in Health really is predicated on 5 principles: access to primary health care, free health care, and education for the poor, community partnerships, addressing social determinants of illness, basic social and economic needs, food, housing, school, and serving the poor through the public sector, which means that we partner with ministries of health directly and we follow their lead. And so what we've seen is that through the efforts of the past 20 years, health systems have been strengthened, HIV rates have gone down, and that really, in large part, has been due to kind of a two-pronged approach. One is community-based approaches with community health workers, and another is building of beacon health facilities, really excellent hospitals seeking to deliver excellent quality care, and strengthening existing government district hospitals and existing health center networks, and linking all of those centers of excellence, health centers, and communities through community health workers. So going to mental illness, the data on mental disorders is quite astounding. 1 in 4 people in their lifetime experience a mental disorder. They actually can be treated, and we're really up against significant stigma that has existed for long periods of time. The global burden in children is very significant. It's estimated that mental disorders are a significant cause of disability in children and adolescents, more prevalent than leukemia, diabetes, and AIDS combined. Suicide is the 3rd leading cause of death among adolescents worldwide. At least 1 in 5 kids age 9 to 17 have a diagnosable mental disorder with impairment in functioning. Most don't receive treatment. And I think this last point is really important. More than 50% of adult mental disorders develop before the age of 14. So these are developmental disorders. And there's always new data coming out on the burden of mental disorders. If you look at the red here compared to these other colors, this data estimates years lived with disability comparatively, and so there in the yellow is HIV, AIDS, and tuberculosis. There in the purple is neglected tropical diseases such as malaria. There in the lime green is cardiovascular and circulatory disorders, and there in the red is mental disorders and their burden globally. And we've got an issue, which is that if the global burden of mental disorders is estimated at 15%, ministries of health globally tend to spend less than 1% of their budgets on mental health. So you see here development assistance for health per area, and you see mental illness at the bottom, 0.4%. And so the challenge is that most of those resources go into locked psychiatric facilities and powerful medications. So there hasn't been a focus on community-based approaches. And so in low and middle income countries, between 75 and 90% of people with severe mental disorders don't receive treatment. But in high income countries, between 35 and 60, I think in the US, we're still somewhere in the high 50s in terms of people living with mental illness who do not receive treatment, which is quite profound. And we face a lot of challenges across our sites to mental health, the impacts of poverty, natural disasters, violence in society, lack of formal mental health services. There are no specialists. So in Haiti, where we work, 10 million people, there are around 5 psychiatrists and 1 neurologist. In Rwanda, where we work, 10 million people, 3 psychiatrists, 1 neurologist. So there's a need for specialists, and there's a need for what are called task-sharing approaches, which means having non-specialists deliver some of the services, and there's a need to integrate and remove the silo that exists for mental health, where it's always split off from health systems. So this is Chiapas, Mexico. It's a beautiful place. They grow coffee, and we have a team there that drives 8 hours at a time to visit a set of patients. And so this would be an example of one of the things we'd see if walking down this street in this town is we've met many people who are chained at home. We see this actually across our sites. This is a gentleman who was chained at home, and it sounds terrible, but the fact is that when you talk with the families of these people, most of them are wonderful people. They literally have no options. There's no treatment. Their family member will either die being killed or will get hurt themselves, or in rare instances would hurt someone else. But literally people have no options. And this is a little house that a family built behind their house, and they spent all their money on the door for this little house, and they had a relative in there who was chained for 20 years. And that relative actually is very functional now, basically visited by a community health worker and receiving medication and a little bit of support. So we see these glaring situations, and we see them quite a bit. This was a patient in Rwanda who had been chained at home and showed up at our hospital with an infection. So the reason they came to the hospital was because they had an infection. And so what we've been doing is basically developing community-based services that lead us to eliminating these services, these problematic practices. So global mental health is an area of study, research, and practice that places a priority on improving mental health and achieving equity, really talking about a social justice, human rights-based approach to mental health for people worldwide. And the broad themes are, we have treatments and interventions that work. We need greater investments from governments, foundations, and others. We need to ensure access and coverage for more people and take a public health approach. And we need to focus on the person as a whole rather than an aggregation of separate diseases or illnesses. And I think this all applies to the United States as well. There are multiple entry points into global mental health. One is really what I focus on, which is improving health care delivery systems, but also thinking about school-based mental health and more strength-based approaches, thinking about displaced populations and refugees, and of course thinking about people living in post-conflict, for example, all the people fleeing Syria, post-natural disaster, for example, Haiti, or epidemic and post-epidemic, such as Ebola and the situation in West Africa. And we also want to take what I'm calling here an eco-bio developmental approach, where we think about the effects of chronic stress and the effects of stress on people in context, and the roots of unhealthy lifestyles, maladaptive coping, and the impacts of fragmented social networks, because an underlying theme here is also we live in a time of incredibly rapid social change. We've never had this kind of social change, probably in human history. And so what are the effects of that on mental health? In 2011, the World Health Organization developed what's called the MHGAP Intervention Guide. And if you go online, you can find interesting things happening at WHO in terms of trying to develop basic agreement and consensus around evidence-based practices that can be transferable across cultures. That we can talk about culture, and culture is important, but there are universals that are really important in thinking about mental health. So, for example, the MHGAP curricula offer evidence-based guidelines for evaluation and treatment of priority conditions such as depression. So Rwanda, I'll just cite Rwanda and our work there. Rwanda, actually, yesterday was the 22nd anniversary of the first day of the genocide. So 1 million people were slaughtered in 100 days in Rwanda 22 years ago. But the story of Rwanda over the past 22 years has really been one of resurgence and recovery. If you go to the genocide memorial in Kigali, you'll see information about the genocide, and you'll also see some reference to mental health and the fact that sustaining psychological, physical, and emotional support for the victims of trauma has been almost impossible to provide because of the numbers of survivors and the prioritization of resources. But actually, Rwanda has been doing quite a good job dealing with mental health. The government has very limited budgets for mental health, but they actually have a psychologist at every one of their 40 district hospitals. They have psychiatric nurses at their hospitals. This is a hospital that we built with the Ministry of Health that opened in 2011 in a very rural area. And what we've been doing is piloting community-based models and showing their efficacy. So what we've been doing is training generalist nurses at health centers to deliver mental health services for people who present to the health centers, and supporting and sustaining clinical supervision, and also evaluating, monitoring outcomes, clinical outcomes. And we have very good data showing improvement. This is one of our social workers here who works to link the patients to community health worker networks in the community. And so we've seen really a lot of improvement for people living with severe mental illness who really didn't have access to treatment before. I've been involved in Haiti since 2010. This is a picture I took a couple weeks after the earthquake. This is the nursing school. The entire second-year nursing class died in the earthquake. That's the 6th floor of the building there on the 1st floor. And this is 1 block from the National Psychiatric Hospital, which also crumbled. This is a gentleman probably who had been in that hospital, but the fact is that there were really no community-based mental health services in Haiti. Partners in Health basically provides services in this pink area to a catchment area of 1.3 million people, 10 hospitals, 5,000 staff, 2,500 community health workers, all of whom are Haitian. And after the earthquake, there were these, these incredible internally displaced person settlements, hundreds of thousands of people displaced. And so there was really a bad situation. And then there was negligible psychiatric or mental health services aside from the psychiatric ward that had been built in the 1950s, and people living under very poor conditions in that ward, which actually have not changed much over the past 5 years. And so we started to deliver services in the IDP settlements and then moved those services to our sites. And this woman on the left is Tatiana Terezme, who is one of only 3 psychologists at Zan Milasante, Partners in Health in Haitian Creole, when we started. Now we have 15 psychologists and 50 social workers, and we have community health workers engaged in treatment. The woman sitting in the middle, Esther, she had been found by missionaries wandering the countryside, psychotic after the earthquake, and basically has received care, going to school, doing very well. And so we have a team. And fundamentally what I do is I work from Boston, I travel to the sites, but our cross-site mental health team basically supports the supervision and training of these local implementation teams, which are comprised of local providers. So these are our psychologists. And as I mentioned, this concept of task sharing, what we've been doing is working with teachers and community health workers to do active case finding and following people to their homes, working with the psychologists and social workers to provide targeted psychological interventions, asking the physicians to do some medication management, and then putting in the infrastructure for quality oversight and supervision and consultation. We work to develop screening and tracking tools that really, these are the kinds of tools we should be using in this context here in the US as well. This is a depression screening tool that we developed using local concepts of distress. Developing a system of care, articulating care pathways for things like depression and psychotic illness and epilepsy, high burden disorders. Developing curricula, training, and supervision systems that are sustained, and this is a huge issue, is how do you sustain supervision? And then engaging with schools and engaging in communities. So for example, we've been training teachers to recognize, respond, and refer youth with mental health problems, and also been teaching them skills to support resilience in their students. And I'll just close on another thing we do, which is in trying to not just support training, clinical training for local providers, we're also trying to support career development for local implementers. So this is Dr. Reginald Fils-Aimé. So Dr. Fils-Aimé grew up in a very rural part of Haiti. He was an excellent student. He became director of the tuberculosis program at PIH in Haiti. And with the earthquake, he always had an interest in culture. He's a Renaissance man, very eclectic, and he was interested in mental health. And so when the earthquake happened, he started to, we had no physicians doing mental health, so he started helping us with mental health care in the community. And basically we supported his training to basically be a physician leader on our team, as we've been training physicians to deliver mental health services, non-specialists. And so he became the mental health director at a new hospital we built in Mirabel, Haiti. This is a patient. So if you go on the PIH website, his name is Paul Mainardi, and there's a whole story on him. So he was 22. He had become psychotic, was wandering the countryside, and his family brought him to the church, and the priest almost killed him in an exorcism ceremony. And so he ended up at our hospital, not dissimilar to the woman who had developed the infection. He came to our hospital unconscious because he had been choked in an exorcism ceremony. And basically he received basic psychological support, a little bit of medication, proper diagnosis. And so he did very well, and he developed a radio station in the back of his house. And so if you go on the PIH website, you'll find his radio messages about mental health care, and they're much more powerful than anything I can say. So this is non-alcoholic wine. Dr. Fils-Aimé brought some wine, some sparkling cranberry juice, and so we have people like Dr. Fils-Aimé who want to provide mental health services, and they want careers in mental health care, but the trajectories haven't existed. And so he's now a master's student in global health delivery at Harvard, and he's finishing his thesis this spring. And so actually his project, he did a qualitative assessment of patient and family experience of the system of care. So he did a bunch of anthropological work. So he's now considering a PhD, but I'm trying to convince him actually to come back and help run the program. So that's really that's it for me. I think we can talk more in our discussion, but I think this gives you a flavor for the kind of work we're doing. Thank you.
Thank you. Thank you so much, Beppy. And I'd ask Jim if you two would come up here. We'll mic you for the conversation. All right, come on back up, Beppy. So you notice I say Beppy and Jim. I tried Dr. Raviola and Dr. Duffy, but they don't allow that. So please let that be assigned to you to engage in some conversation. And you can do it in the written word by putting your question on the note card. And if you just hold it up like that, like this young woman is doing there, my colleagues will come around and sweep it up and bring it to me for the Q&A session. I'll go ahead and, I love it, lots of questions. I'm going to ask Dr. Jim Duffy to kind of, as a local physician and psychiatrist and community health worker, also working on policy, and as Jim, as you listen to some of the trends and issues that Beppy brought up, tell us, what are your reactions to it as someone who works locally with immigrants and also with general public, and why it's important for us to be listening?
Well, first I want to thank Beppe. That was great. That's just really impressive work. I'm impressed, and some of the things are definitely applicable to what we're doing here, and I'll bring out some of that. But I really want to, since we're having a good response to the number of questions, I'll just say my message is fairly quick and brief and straightforward. The message is that we don't have to actually go to Haiti or Rwanda to practice global health. We have global health right down the street from us. We are a country that's changing quickly, as we heard. I'll point out just a couple of things that sort of support that. Almost 1 in 4 children in the United States lives in an immigrant family, 24%. The other data point that I think is good to remember is that in 2011, we had in the United States more births of non-white children than white children. So our demographics are changing quickly. We have, I'll mention one other though that comes to my mind is that in the past immigrants, maybe, I'm not certain when the threshold was, but at one point we used to think about economic migrants as the predominant number of immigrants we have. But as a matter of fact, now we have mostly refugees or asylum seekers. In particular, in the child population, mostly refugees from war zones or areas of great conflict. Some from disasters, and some from areas of extreme poverty. But what's in the news predominantly, and our largest growing population are Latinos or Hispanics. Mostly from El Salvador, Guatemala, and Honduras, crossing the border in Chiapas near the border with Guatemala, where PIH is working with community health workers. It's a Zapatista autonomous region, and I had an opportunity to visit last year. The PIH workers are doing an incredible job with reaching out and organizing communities. In particular, I was very impressed with the reduction in perinatal mortality in that area compared to Guerrero and some of the states close by. They've, in that particular region with PH, community health workers, and coordinating with the Catholic Church in San Cristobal, they've dropped the perinatal mortality close to 0. It's really pretty remarkable what they're doing. So how does that relate to the present day? Clearly, and Columbus has 2 or 3 large populations of immigrants, the Nepali Bhutanese, for sure. The Somali groups, Columbus has the second, I think, most populated Somali community. And we have a fairly hidden community, I think, of Hispanics on Hilltop region and other places. Hidden because there are major access problems both to physical health, pediatric health, but even more so to mental health services. Most of the children that we see that have experienced the local violence in Honduras and the triad, Honduras and El Salvador and Guatemala, those children have been exposed to a tremendous amount of early childhood trauma, and in particular, a large percentage of close to 90% or so have been separated from their parents for some months at a time, at least during the pre-migration phase or during the migration phase. And as a matter of fact, we won't get into this a whole lot, but there are at least 3 family detention centers in the United States that are holding literally thousands of mothers and children in detention centers waiting for asylum applications to go through. There are 2 in Texas and 1 in Pennsylvania. So there's some really fairly current advocacy opportunities in that regard.
Great. Thank you. Thank you. Let me start. We got a lot of questions already, and don't forget, just hold it up, or hashtag AskCCWA if you're on Twitter. This one comes from the audience. It's interesting that mental health issues do not respect socioeconomic status, poor or rich. are affected equally, while unlike in many other diseases. So the question is, do you find this true globally? And what are the overarching factors or determinants governing this commonality? Either of you, Beppe, do you want to take that first? Global man?
There's this thing called the genome. I mean, I think that, so an interesting thing is, one of the challenges I face in my role at Partners in Health, talking about social determinants, is, mental disorders are not primarily socially caused. They're biological illnesses that there's an interaction at the DNA level with environment. And everybody has a different genetic makeup. And each of us is sensitive in different ways to our environment. So there's a complex interplay of context and biology that affects mental illness. That said, poverty and some of the things I describe, of course, are going to be also promoting of poor mental health outcomes. I think one of the most fascinating things we can ask ourselves is, why are some people resilient who have faced incredible adversity and who thrive, and why do others not? And there's all kinds of interesting science around that. But I would concur with the idea that the universals are more common than the differences. And so, yes, we see different gradients of a burden, whether it's in urban centers, social networks. There's all kinds of really important aspects to culture and social networks. So, for example, some cultures might not be open to the concept of the more biomedical concept of mental illness, but there's a level of social cohesion and cultural fabric that really helps people feel supported and is probably protective. Did I answer the question?
Yeah, thank you. And I was thinking about, as the question related to class, I'm also thinking about culture, and maybe Dr. Duffy, in your work with some of the immigrants or what you've heard, what role does cultural competence have in delivering mental health care? And maybe you can also touch on stigma,
Sure.
by culture, if you know.
Cultural competence in terms of the workers, or identifying, yeah. So I almost will bounce that question to Beppe, because I'm very fascinated by the idea of how to use local traditions and religious traditions and cultures to actually to partner with them to help improve access to mental health care. Certainly with certain cultures, stigma is huge. As one of the benefits of integrated primary care, having mental health people in with primary care, because obviously if a person is in the reception area, you don't know whether they're there for a sexual abuse exam, a physical exam just for a well child visit, or a visit to a therapist. So you have a whole range of things. So having integrated programs, I think, is one of the solutions. But there are some, certainly when dealing with an immigrant family, I think understanding their culture and understanding the terminology that people might use for certain illnesses. I remember that I took care of a man one time who had recurrent fevers from Mexico, and his illness was susto, and susto turned out to be susto is a word that means surprised. That he was surprised by a snake, and that was his understanding for why he was having recurrent illnesses. So understanding that, and particularly in child abuse, understanding the different presentations that are culturally appropriate, like cupping, for instance, seeing different interventions that families have. I would also say that in particular, the group that I know mostly is the Latino group, and there are problems with access because two things. One is that the children are learning English before the grown-up students, so there's a tendency to use the children as interpreters. That's wrong. Can't do that. You make too many mistakes. You have to have some trained interpreter that can understand the mental health problems of how to talk about mental health. The other issue that I might say is that there's an access problem with the Latino population because many children live in mixed legal status families. And so they don't want to rise up, they don't want to identify themselves as having a problem because they might identify, they might have an ICE worker knock on the door to deport a family member because so there are particular problems with access to mental health for children.
Can I follow up to that
Sure,
with a question
absolutely.
here that's related? As a public school teacher in a diverse district, I work with families who still carry a social stigma of accessing mental health services, especially since many of our families come from collective cultures. How can we best serve our students and their families in terms of accessing mental health services? It's for either one of you, or both.
I'll just say first, and I'd like to turn it over. I think the psychoeducation in elementary school, I think, is absolutely important. And matter of fact,
What's
psychoeducation is sort of understanding emotional development along with physical development, understanding emotional development, particularly function within families, letting younger kids know that it's okay to talk about feelings. Particularly, we were talking this morning about interventions, school-based interventions for kids who have been exposed to trauma. I think it's absolutely an important pathway into helping kids through the school system because the families are less likely to seek care. Go ahead.
Anything to add? Or?
So with regard to culture, I think you're talking from the experience of an American physician, for example, working with an immigrant population. As you saw from the pictures I showed you, there's no foreigners in the pictures. So I have some psychiatrists, fellows, like early career psychiatrists, U.S. psychiatrists, who spend time at our sites. But they are not to see patients alone, actually. So they're actually supposed to basically be behind the local provider and accompany the local provider. But even therein, there are challenges because most of our university-trained psychologists who are local providers actually aren't local. They come from urban centers. They've been trained in amalgamated schools of psychology, which are mostly European influenced. And so our teams go through processes of getting their training and then integrating what they learned in school with what local knowledge they have. So even like in Haiti, speaking French or Creole, there's a big difference. And people have different strengths. Some Haitians don't speak good Creole. Some have been educated in French. So and at PIH we have many different, let's say, kinds of staff because we have local elites who have trained in urban capitals. We have people who deliver services in the local community. So from the perspective of culture, it's much more it's incredibly nuanced because it involves the provider and the provider's relationship and power dynamics with the people they're treating. I'm not disparaging the church by telling you the exorcism story because I think religion serves a critical function. Traditional healers serve a critical function also, and we interact with the traditional healers a lot. And in fact, in 2010, after the earthquake, when we did a qualitative study to look at local perceptions to inform what we did, it was a lot of the traditional healers and the voodoo priests who said, we need help with this, we can handle this, and depression is a big priority, and we need psychologists. At the same time, sometimes, for example, our psychologists get frustrated because patients will come having seen 5 or 6 traditional healers with no money. Not that the patients are expected to pay for the services, but they're complex dynamics, and the bottom line is we work with the traditional healers as best we can and try to integrate local methods as best we can, but we're also interested in where it's appropriate, applying what we also know can work. And it's an iterative process with our local teams about what evidence-based practices we apply, since the evidence-based practices have been delivered and developed in the global north. But it ends up working out because I do believe that the universals are much more in play than the differences, and people generally respond very well. I'll give you another story which I like to tell because I still can't believe it. in a couple weeks after the earthquake, our director in Haiti is a priest and a psychologist. So he said to me, we're going to meet with Acupuncturists Without Borders. And I said, I said, what are you talking about? He said, we're going to meet with Acupuncturists Without Borders. So we went to a hamburger store, and Acupuncturists Without Borders performed acupuncture on us, and this auricular acupuncture technique.
At the hamburger store?
Just outside. And you know, so our psychologists in Haiti, they love acupuncture. They carry needles, and they do acupuncture. And I never would have expected that. Or Tatiana, the psychologist you saw there, you know, one of my first times seeing patients with her, there was a guy who came in, a farmer who had headaches and back pain and was very stressed. So she said, I'm going to do a relaxation exercise on him. So I was thinking, all right, this is going to be an interesting Haitian technique. She pulled out her computer and she put on an Andrea Bocelli video. And the patient fell asleep in the chair. So, you know, you got to be flexible, you got to be open, and you have to check your assumptions at the door.
That works for me too.
Yeah. I might pull a couple of things out before we move on about resilience. Resilience is something we like to promote. We like to promote it in schools. First, we need to know what it is. And I think we all have sort of an idea what resilience is. It's somehow flexibility of coming out with a good result when there's adversity in general. But there's two things we've sort of been talking around that are really important contributors to resilience. And one of them actually is a strong connection with a culture or a church. Epidemiologically, it's very important for people to maintain their connection to the source culture. And particularly with immigrant children, if you look at the best outcomes of immigrant children are the ones that take from their source culture and from their receiving culture almost evenly. So the kids who are bilingual and the kids who are well connected to their source culture, and they're also connected to the receiving culture. Those are the kids that have the best outcome. But the one factor that is most important for resilience is a long-term supportive relationship with a connected adult. So part of working with families is talk to the adults, talk to the kids that are in school. You bring the adults in as well, and you promote resilience. Now, some of the other things about resilience are things like executive functions, being able to control your emotions, and that's absolutely important with adults, being able to self-regulate and not be overly responsive in the presence of children, even in the face of adversity. But those are the two things I wanted to point out at this point in terms of what we could think about in terms of policies of how to introduce resilience in children. One is the relationship with at least one supportive adult, and the other is connection with culture, particularly a church or a faith community, connection with a faith community and with a cultural tradition.
Thank you. I know you've done a lot of work through the Academy for Pediatrics, with the Good for Growth, looking at early days and the power that a relationship has in affecting
Exactly.
health.
We have a program called Promoting First Relationships. So we're working with pediatricians in Ohio to help identify different problems with mother and or caretaker and children relationships, and help them gain a different developmental path even as early as the second or third year of life. And we hope that we expect that to have long-term outcomes.
Great. Let me switch. On the drive over here from our earlier meeting, I was asking Beppe in his practice if he's seen any trends. And he thought about it, and then he said, screen time. I thought, man, that's my life. I got a 10-year-old. He's like, and he was telling me it's almost like an addict who's getting off heroin. You pull the thing. So let's switch to technology. But there's good sides of technology too, and especially in mental health. This question says, mHealth, or mobile phone interventions, could be an opportunity for reaching mental health needs globally. Could you discuss where you see mHealth having the most use and what it should not be used for? Call of Duty.
So, so mHealth is the use of cell phones or tablets to help direct care. And in Haiti, we've had a pilot using mHealth, using tablets, where our community health workers had our curricula and other tools, and we're also entering data. And I think it's incredibly promising. Telehealth is something else that people talk about as promising, and
What's that?
So telehealth is the use of video, for example, for teaching and supervision. So there's some really nice examples, like in New Mexico, there's a very cool project called Project Echo, where basically primary care physicians are supervised at health centers and delivering services, including for mental health. And there's different ways to do it. There's actually an American Telemedicine Association now, and so there's a lot of promise in telehealth. So for us, the mHealth does hold promise, but we're always cautious about any new modality, like watering down the actual services being delivered and actually exhausting the providers. They're supposed to be helpful. So our mHealth pilot was feasible, but was taxing on the team in terms of developing it. But I think also one of the challenges we face generally is that there's so few resources for the work we do that our providers are the implementers and do everything else, and they're also expected to develop research and sort of manage projects. And I think mHealth is incredibly promising, but there has to be infrastructure to support it being used well. But I think for us, for example, where I was showing you these tools, we've developed depression screening tools, care support tools. No clinician can sort of hold that in their head. They need a manual, or they need, and I think that having it on a cell phone is much, much more helpful than having to carry like a binder around.
Great. We're entering the speed round. So you're going to be limited to your time, or I'm going to move it along, because I want to try to get through some more of these. And this one maybe for Beppe, and this comes from a student at Denison. I know that Partners in Health works primarily with victims of natural disaster, violence, et cetera. However, regarding the situation with refugees around the world, what do you think is the most important improvement that refugee resettlement programs in the U.S. need to make regarding mental health? Go.
So Partners in Health is not a disaster relief organization, and this is a very important distinction because it puts us in a difficult position. Partners in Health works to strengthen health systems with ministries of health. What happens, though, is that disasters then happen where we work. So that happened in Haiti. With Ebola, we did respond to Ebola. So I have friends who are experts in refugee mental health. I don't have a good answer for the question because I'm not an expert in refugee mental health in the U.S. context, although I have a great interest in it. But I'm very happy to direct you to the right people, as well as others.
Well, I'll say two things. One is for the children who are that present the undocumented immigrants, they need to be moved over into the Department of Human Services as soon as possible and out of the ICE facilities, the Immigrant and Customs Enforcement facilities. Right now, they stay in the ICE facilities sometimes for months at a time. So they need to be in DHS, and they need to be in foster care homes that are culturally informed. Second thing is, as much as possible for the other group of kids, they keep the kids and the families together, and they don't separate them out. Those are the two things that comes to mind very first because of the reason what I talked about before in terms of promoting resilience, keep families together.
Great. All right, you get 10-second response. Beppe, for Director General of the WHO, Margaret Chan, says, hey, Beppe, I don't have a lot of time. I've got $1 billion, or I don't know what the number is. Where should we invest it in terms of mental health? And the elevator doors are closing. So what do you say?
I'm going to meet her next week.
Perfect.
I am, actually. But I haven't thought through what I'm going to say. Well, WHO has to commit more resources to mental health. The mental health program at WHO is thin. And so the capacity of WHO to work with ministries to give the resources. And so next week there's a World Bank meeting with ministers of finance. It's in global mental health, and it's really trying to impact the ministers of finance because the ministries of health are impacted by the ministers of finance who determine their budgets. So, for example, there's no budget for mental health in Haiti. In Rwanda, it's minuscule. So that's the key issue: financing.
Okay, Dr. Duffy, Donald Trump calls you up and says, "I'm getting ready to become president, and I need to know, like, what should I do if I'm elected? What should I do in terms of mental health?" And I just can do one thing.
Just answer the question.
Yeah. Find me a place to live in Nova Scotia.
All right, last question for you both. This is also the speed round as we exit. Most of us here are not in this field day to day, and I know I appreciate those that are every day. How can we make a difference? What can we do as we leave, or we're just like regular citizens doing our regular jobs that don't have to do with mental health specifically? How can we make a difference so that this ends up being an atmosphere of hope and change? Dr. Duffy.
Wow. Well, I think that the more we become informed and the more we integrate the values that we really believe in the United States in terms of accepting the stranger, being able to be I'm a second or third generation Scottish immigrant, and so we're all immigrants, and this is a time that we dig down deep and we become compassionate, and we accept our value of receiving the stranger, which is part of our cultural and religious history.
Thank you. Debbie?
This World Bank meeting next week is called Out of the Shadows, and I would say that sort of stigma and fear and unconscious bias around mental health, I think, promotes fear and sort of addressing it or bringing it up, and I think people should be sensitive to that wherever they work.
Great. Ladies and gentlemen, please join me in thanking these fantastic individuals.